All right, so today we're taking a deep dive into something every GP deals with on a daily basis.
Abdominal pain.
Hmm, yeah, one of those things that you can never quite escape, right?
Exactly. But for this deep dive, we've gone through tons of research articles, clinical guidelines, even some really interesting case studies. And we're going to focus on how GPs can actually use this information in their practice.
Sounds good.
So one thing that always makes abdominal pain tricky is referred pain, right? A patient might be pointing to their shoulder, but the problem is actually their gallbladder.
Yeah, referred pain can really throw you off. It just goes to show how crucial it is to understand the nerves involved.
So walk me through this referred pain thing. What's the science behind it?
Well, it all comes down to those pain signals and how they travel to the brain. You see, nerves from different parts of the body can enter the spinal cord at the same level.
Okay.
So the brain gets a bit confused, like, wait, where's this signal actually coming from?
So it's like a traffic jam in the spinal cord. That's a great way to put it. And that's why getting a really detailed patient history is so important.
Makes sense?
We've got to ask the right questions to tease out if that pain is really localized or if it's being referred from somewhere else entirely.
Now, you mentioned the gallbladder and shoulder pain earlier.
Yeah.
What are some other classic examples of this referred pain that we GPs should be aware of?
Oh, there are a bunch. Like pancreatitis is a big one. That pain can radiate to the back and totally mimic a musculoskeletal issue.
Interesting.
And then you've got kidney stones. That pain can shoot down to the groin and make you think it's a urological problem when it's not.
Okay, so we need to be on the lookout for these patterns.
Hmm.
But what's the takeaway for us GPs? How does knowing about referred pain actually change how we approach abdominal pain?
It's a reminder not to jump to conclusions just based on where the pain is.
Right.
We have to consider all the possibilities, ask really detailed questions, and do a thorough physical exam every single time.
Basically connecting the dots and seeing the bigger picture.
Exactly. And recognizing those patterns, it can help us avoid unnecessary tests or referrals, too.
Okay, makes sense. Now let's switch gears a bit and talk about the different types of abdominal pain. You always hear about upper versus lower abdominal pain. What's the significance of that distinction?
Well, the location of the pain, it gives us really valuable clues about what could be causing it.
Okay.
It helps us narrow down the list of potential culprits.
So like a starting point.
Yeah, exactly. It's like the first piece of the
All
puzzle.
right, so let's take a little virtual tour of the abdomen. We'll start with the upper region. What are the key organs we should be thinking about up there?
Well, you've got your stomach, liver, gallbladder, pancreas, spleen.
Wow, that's a lot going on in that one space.
It is a whole lot going on up there, and each of those organs can present with its own unique pain patterns.
Okay, let's break it down a bit. Let's say a patient comes in complaining of right upper quadrant pain. What are some of the top diagnoses that should be on our radar?
Okay, well, in the RUQ, the gallbladder is a really common culprit. Gallstones can cause that really intense colicky pain that often radiates to the back. And then if the gallbladder itself gets inflamed, the pain can be even worse.
What about the liver? What kind of pain do we see with liver issues?
Liver pain, it's often described as a dull ache or a feeling of fullness in that right upper quadrant. It could be a sign of hepatitis, cirrhosis, even liver cancer.
Wow, so lots to consider in just that one quadrant alone. Now, what about pain in the epigastric region? Right smack dab in the middle of the upper abdomen.
That's where things get really interesting.
How so?
Because the epigastric region, it can be a bit tricky. It often points to problems with the stomach or the pancreas.
Like what? Give me some examples.
Well, you've got peptic ulcers. They're a classic cause of epigastric pain, often described as a burning or gnawing sensation. And then there's pancreatitis. Pancreatitis can cause intense, boring pain that radiates to the back.
And remember we were talking about referred pain earlier. Epigastric pain can actually be a sign of a heart attack, especially in patients with risk factors.
That's a really important point. And it just goes to show how critical it is to think about the patient's overall clinical picture, not just their abdominal symptoms in isolation.
So it's like being a detective, gathering all the clues.
Yeah.
Now, what about that left upper quadrant? What's hiding out over there?
The left upper quadrant, that's primarily the domain of the spleen.
Okay.
So if the spleen's enlarged, which can happen for a whole bunch of reasons, it can cause pain or discomfort in that area.
Is there anything else we need to be thinking about in that area?
Well, less common, but definitely things to keep in mind. Splenic infarction, an abscess, and don't forget about referred pain. For example, pain from a heart attack can sometimes radiate to the left shoulder or arm.
Got it. So we've covered the big three areas for upper abdominal pain. Right upper quadrant, epigastric, and left upper quadrant. Lots of possibilities, and it seems like there's a lot of potential for overlap.
Absolutely. That's why it's so important to be methodical, to ask the right questions, and to listen carefully to our patients.
Because sometimes it's those subtle clues that point us in the right direction.
Exactly.
All right, well, we've explored the upper abdomen. Now let's dive below the belly button and talk about lower abdominal pain. What are some of the key differences we see when pain strikes in that region?
Well, lower abdominal pain, it tends to be even more common than upper abdominal pain, and there's a wider range of potential causes to consider.
So what are the big players in the lower abdomen?
You've got your intestines, your appendix, your bladder, and of course in women, the reproductive organs.
All right, let's start with some of those common causes of lower abdominal pain that we see in both men and women. What comes to mind?
Well, appendicitis is a classic one. It usually starts with pain around the belly button and then it migrates to the right lower quadrant.
Right.
Often comes with loss of appetite, nausea, vomiting.
And that migration of the pain, that's a key feature, right?
Exactly. That migration is a big clue. Now, what about diverticulitis?
Okay, yeah. How does that typically present?
So diverticulitis, it usually causes pain in the left lower quadrant, although it can sometimes be on the right side. The pain is usually constant, and it might have been there for a few days before the patient comes in.
Hmm.
You'll often see fever and a change in bowel habits, too.
So location and the other symptoms can help us differentiate between that and appendicitis.
Exactly.
What are some other things we need to be on the lookout for in the lower abdomen?
Kidney stones are a big one. Those can cause a lot of ER visits. The pain can range from mild to severe, usually in the flank, back, or abdomen.
And often radiates to the groin, like you mentioned before.
Exactly.
What about UTIs?
UTIs, definitely a common cause, especially in women. That pain is typically felt in the suprapubic area, right above the pubic bone. Often comes with burning, with urination, and increased frequency.
Right, and if it spreads to the kidneys, then you see those classic pyelonephritis symptoms: fever, chills, flank pain. So we've got our inflammatory causes, our stone-related issues, and our bladder problems. What about lower abdominal pain that's a bit more diffuse? What are some culprits there?
Diffuse pain, that can be a real head scratcher because it doesn't neatly point to one specific organ or system. But there are some things to keep in mind.
Okay, give me an example. I'm ready to put my detective hat on again.
All right, let's talk about bowel obstruction. This one can be incredibly serious, and it often involves severe acute pain that's spread throughout the abdomen.
So what are some of those hallmark signs of a bowel obstruction that we should be looking for?
Patients usually experience nausea, vomiting, cramping pain, and they can't have a bowel movement.
And when you examine them, you might see a distended, tight abdomen with either really high-pitched bowel sounds or no bowel sounds at all.
Right, exactly. Definitely a red flag.
Definitely a red flag.
Now, here's one that every GP needs to know about. Acute mesenteric ischemia.
Ooh, that sounds scary. Tell me more.
It is scary. It's when the blood flow to the intestines gets blocked. A true medical emergency. And the pain is often described as severe and totally out of proportion to what you might see on exam.
So even if they don't look that sick, the severity of the pain could be a huge clue.
Exactly. And it's crucial to recognize it quickly because early diagnosis and treatment are essential. We're talking about saving the patient's life.
Wow. Okay, so what about chronic mesenteric ischemia? How's that different?
Chronic mesenteric ischemia develops more gradually, and the pain is often triggered by eating. Patients might also experience weight loss, nausea, vomiting, and diarrhea.
So it's more of a long-term problem with pain that comes and goes.
Yeah, you could say that. Now, let's talk about inflammatory bowel disease. Those conditions can cause all sorts of symptoms, including abdominal pain.
Right.
You're talking about bloody diarrhea, urgency, that feeling of incomplete evacuation, and even accidental bowel leakage. They might have weight loss, fevers, and pain too.
And the pain can be present for years before a diagnosis is made. So we need to have a high index of suspicion, especially in younger patients. What about infections? Those can obviously cause pain too, right?
Oh, absolutely. Viral gastroenteritis is a classic example. They get diarrhea, nausea, vomiting, and abdominal pain.
Yeah, I think we've all seen our fair share of those cases.
Right, especially during certain times of the year.
Now, what about conditions that are specific to women? We touched on UPIs earlier, but what are some other gynecological causes of lower abdominal pain that we need to be aware of?
Ectopic pregnancy is a big one. It's life-threatening, so it needs immediate attention. The pain is often sharp, stabbing, and it may come with vaginal bleeding.
So any woman of childbearing age with lower abdominal pain and vaginal bleeding, ectopic pregnancy has to be on the radar.
Exactly. You also have to think about things like pelvic inflammatory disease, ovarian torsion, and ruptured ovarian cysts. All can cause significant pain.
Okay, so a lot to think about in the lower abdomen. And it's crucial to consider those gender-specific causes in women. Is there anything else we need to keep in mind when it comes to that diffuse lower abdominal pain?
Well, sometimes the pain isn't coming from an organ in the abdomen at all.
Really?
Yeah, conditions like pneumonia or heart attack can sometimes cause pain that you feel in the lower abdomen.
So we can't just focus on the abdomen. We need to think about the whole patient.
Exactly. You have to consider those conditions that affect other systems but can present with abdominal pain.
All right, good reminder.
It all comes back to that big picture thinking.
Okay, so we've talked about common causes, uncommon causes, special considerations for certain groups. What are some key takeaways here? How can GPs use all this information?
Well, the most important thing is to remember abdominal pain is a symptom, not a diagnosis.
Right.
Our job is to figure out what's causing that pain and then determine the best way to help our patient.
So like we said before, we have to be detectives.
Exactly. We're gathering clues from their history, their exam, and any tests we need to do. It's about putting those pieces together to form a complete picture.
I like that. Now, I know we've only scratched the surface here. There's a whole world of less common causes of abdominal pain that we haven't even touched on yet.
That's true, and that's exactly what we're going to explore in the next part of our deep dive. We'll talk about how to approach diagnosis when those usual suspects have been ruled out.
Sounds good. I can't wait to hear what you've got in store for us.
It'll be fun. I'll leave you with this thought. What if abdominal pain isn't always a straight line to a single diagnosis? What if it's a sign that we need to dig deeper, to think more broadly, and to consider how everything in the body is connected? Something to think about until next time.
I like that. Definitely something to ponder. All right, well, we'll pick up where we left off in part 2 of our deep dive into abdominal pain. Okay, so we're back for part 2 of our deep dive into abdominal pain. Last time we talked about all those everyday causes, the ones GPs see all the time. But you mentioned some rarer, more unusual suspects, too.
Right. Sometimes you get a patient whose pain just doesn't fit those neat little boxes. Those are the cases that really make you think.
So let's talk about those less common causes of abdominal pain. Where do we even start?
Well, one condition that often gets missed is abdominal aortic aneurysm, or AAA.
AAA.
And the tricky thing is most people within AAA don't have any symptoms at all. That's why it can be so dangerous.
So what should make us suspicious? What should we be looking for?
If you have an older patient, especially someone who smokes or has high blood pressure, and they complain of abdominal pain, back pain, or flank pain, you have to think about AAA.
Okay.
And if they describe the pain as tearing or ripping, that's a huge red flag.
Makes sense. A ruptured AAA is a true emergency, so we need to catch it early.
Absolutely.
Now, what about abdominal compartment syndrome? That one sounds pretty intense.
It is intense. It usually happens in people who are already critically ill, and it basically means the pressure inside the abdomen is getting dangerously high,
Okay.
and that pressure can start to cut off blood flow to vital organs. If you don't catch it quickly, it can lead to organ failure.
So we're looking for a tense, distended abdomen. What other signs should we be aware of?
A tense, distended abdomen is definitely key, but you also want to look for things like difficulty breathing, low blood pressure, decreased urine output.
Right, so we're talking about a very serious situation that requires immediate attention. Now, switching gears a bit, have you ever heard of abdominal migraine?
I have, but I remember when I was learning about it, I always thought a migraine was just a headache.
Yeah, me too.
But the classic headache, that's not always the whole story.
So the headache isn't always the main event.
Not always. Some people get abdominal pain as their main symptom.
Interesting.
They often have a history of migraine headaches, but sometimes the abdominal pain is the only clue. And that can make diagnosis a real challenge.
So if we have a patient with recurring episodes of abdominal pain and no other obvious cause, abdominal migraine should be on the differential.
It should be, especially if they have those other migraine-related symptoms. Nausea, vomiting, sensitivity to light or sound. It's often a diagnosis of exclusion, but it's important to consider.
Okay, definitely one to keep in mind. Now, what about angioedema? I know that's about swelling, but how does that relate to abdominal pain?
Angioedema can actually affect any part of the body, including the intestines.
Ah,
It can be hereditary or it can be triggered by medications like ACE inhibitors.
right.
So if someone on an ACE inhibitor suddenly develops abdominal pain and swelling, you have to think about angioedema.
And the pain can be pretty severe, right?
It can be, often comes with nausea, vomiting, and diarrhea too.
So it's like an allergic reaction, but it's happening inside the abdomen.
That's a good way to think about it. It's basically an immune response that causes swelling and inflammation, and that's what leads to the pain.
Okay, that makes sense. Now, you mentioned before that sometimes abdominal pain isn't actually coming from an organ in the abdomen. Can you give me some more examples of that?
Oh, sure. It's important to remember that the body is all connected. Pain can be referred from one place to another.
Right, like we talked about with referred pain.
Exactly. So a patient might come in complaining of abdominal pain, but the real problem could be pneumonia or even a heart attack.
Wow. We really can't get tunnel vision when we're evaluating abdominal pain. We need to think about the whole patient.
You got it. You have to consider those conditions that affect other systems but can present with abdominal pain.
Okay, good reminder. Now, I know there are also some specific populations we need to think about differently when it comes to abdominal pain.
That's right. Certain groups just have unique considerations that can change our thinking.
Okay, so who are we talking about?
Well, women, for one. You always have to consider gynecological causes in women of reproductive age.
Right. Things like ectopic pregnancy, PID, ovarian torsion.
Exactly. And then you have postoperative patients. Surgery can really mess with the digestive system, and that can lead to all sorts of complications that cause pain.
So we need to be extra careful with those patients.
Absolutely. And then there are patients with sickle cell disease. They're prone to those really painful abdominal crises.
And what about people with HIV? Any special considerations there?
What? HIV weakens the immune system, so those patients are more likely to get infections that can cause abdominal pain. They're also at higher risk for certain cancers that affect the abdomen.
Okay, so lots of factors to consider. It really is like a giant puzzle, and we have to use all the pieces to get the full picture.
That's a great way to put it, and that's what makes it so challenging and so fascinating.
Okay, so we've talked about a lot of those less common causes of pain and special considerations for certain groups. What are the key takeaways here? How can we actually use all this knowledge in our practice?
Well, the most important thing is to remember that abdominal pain is a symptom. It's not a diagnosis.
Right.
Our job is to figure out what's causing that pain and then come up with the best way to help the patient.
We have to be good detectives.
Exactly.
Hmm.
We need to gather information from the history, the physical exam, and any investigations we need to do, and we use all of that to figure out what's really going on.
It's all about connecting those dots, like we said before.
It is. And we need to be comfortable with uncertainty, too.
Wow.
Sometimes, even after you do everything right, you still might not know for sure what's causing the pain.
So what do we do then?
You have to be honest with your patients. Let them know that you don't have all the answers, but you're going to keep working with them to figure it out. And
Right.
you're going to do everything you can to help them manage their symptoms.
That makes sense. It's about building trust and a strong relationship with your patient.
Exactly. And it's about knowing when to ask for help. Sometimes you need to call in a specialist, a gastroenterologist, a surgeon to help get to the bottom of things.
This has been such a helpful deep dive. We've gone over so many different aspects of abdominal pain, from the common causes to the rare ones that can really stump you.
And we've talked about the importance of listening to your patients, doing a thorough exam, and using all the tools you have to figure out what's going on.
Right. It's about being a detective, but it's also about being a good doctor, being compassionate, being thorough, and always advocating for your patient.
I couldn't agree more.
Well, on that note, I think it's time to move on to the last part of our deep dive.
Sounds good.
In part 3, we're going to focus on how to actually approach the diagnosis of abdominal pain. We'll talk about the key questions to ask, the essential parts of the physical exam, and when to order lab tests or imaging studies.
It's all about putting those diagnostic skills into practice.
Exactly. All right, well, we'll see you back here for part 3 of our deep dive into abdominal pain. We're back for the final part of our deep dive into abdominal pain. And honestly, after all this, I'm starting to think a GP needs a whole separate brain just for abdominal pain.
Yeah, I can feel that way sometimes. We've covered so much, from common causes to the really rare stuff that can make you scratch your head.
And it's amazing how many of these conditions can mimic each other. It really shows you how important a thorough history and exam are.
Absolutely. You can't underestimate those basic skills. They're the foundation of everything we do as GPs.
So let's shift gears a bit and talk about how we can use all this knowledge when we're actually seeing patients. What are some of the key takeaways for GPs who are listening in?
Well, the most important thing is to remember abdominal pain, it's a symptom, not a diagnosis.
Right.
Our job is to figure out what's causing that pain. And then we can figure out the best way to help our patient.
So it's like solving a puzzle, right? We need all the pieces to see the full picture.
Exactly. And those pieces come from the history, the physical exam, and any investigations we need to do.
Okay, let's talk about that history. What are the essential questions we need to ask our patients when they come in complaining of abdominal pain?
Well, you want to get a really clear picture of the pain itself. Where is it? What does it feel like? Is it sharp, stabbing, cramping, burning? How long has it been going on? What makes it better? What makes it worse?
Right, right. And don't forget about associated symptoms.
Absolutely. Things like fever, nausea, vomiting, diarrhea, constipation, those can all give you clues. And then you want to ask about their past medical history, any medications they're taking, any family history of abdominal problems.
Okay, so we've gathered all this information from the history. Now we're ready for the physical exam.
Yeah.
What are the key things we should be looking for?
First, you want to just look at the abdomen. Are there any signs of distension? Scars, rashes? Then you palpate gently. Check for any tenderness, guarding, or masses. And don't forget to listen to those bowel sounds.
And we always want to be checking for signs of peritonitis too, right? Like rebound tenderness or rigidity.
Exactly. Those are red flags that tell you this is serious.
Okay, so we've got the history, we've got the physical exam. How do we decide when we need to order further investigations?
That really depends on the patient and what you're thinking based on their presentation. Sometimes basic blood work can be helpful, or a urinalysis.
And imaging studies, x-rays, ultrasounds, CT scans can help us see what's happening inside the abdomen.
Right. Those can be really helpful for visualizing the organs and looking for any abnormalities.
And sometimes we might need to refer the patient to a specialist.
That's right. Sometimes you need the expertise of a gastroenterologist, a surgeon, someone who can really dig deep and help us figure out what's going on and come up with the best treatment plan.
Okay, so we've talked about history, physical exam, investigations. What about treatment? I know it always depends on the underlying cause, but are there any general principles we should keep in mind?
Well, if possible, you want to treat the underlying cause of the pain, but you also need to make sure you're addressing the symptoms. That might mean pain meds, anti-nausea meds, IV fluids if they're dehydrated.
And it's important to educate our patients too. Let them know about their condition and what they can do to help manage their symptoms.
Absolutely. We're a team, and that includes empowering our patients.
This has been such a great deep dive. We've explored so many different aspects of abdominal pain, from the common causes to the rarer ones that can really throw you off.
And we've talked about how important it is to listen to your patients, to do a thorough exam, and to use all the tools at your disposal to get to the bottom of things.
Right. It's about being a detective, but it's also about being a good doctor, being compassionate, thorough, and always advocating for your patients.
I couldn't agree more.
Well, on that note, I think it's time to wrap up this deep dive into abdominal pain.
It's been a pleasure talking about this with you.
Thanks for joining us. We'll see you next time for another deep dive.